Hello and welcome to another episode of the Mental Wealth Mastery Show. My name is Rani. Today's episode will shed some light on how difficult it can be for some to come off psychiatric drugs. This is particularly true if they have been on a higher dose and been on medication for a long time. Also, there's very little help out there. I'm speaking to Adele Framer today. Adele learned it the hard way when her withdrawal symptoms were misdiagnosed by many professionals as a relapse of her depression.
I am not of the opinion that patients should be doing it for themselves. I think that they should be able to talk to their doctors, and they should be able to trust their doctors to be able to help them with this extremely common condition. There's so many people taking antidepressants and other psychiatric drugs now. That withdrawal from these drugs is an extremely common problem. Yeah. And doctors are just not prepared for it. It's very, very upsetting.
Not only did she carry out extensive research on the topic and managed to come off her medication by herself, but she also founded the survivingantidepressants.org. This is a critical and comprehensive peer support website that features several thousand case histories of psychiatric drug withdrawal. Let's talk to Adele now.
Thanks so much. I'm looking forward to our conversation.
So first of all, I would like you to share about your journey as a patient on the receiving end from mental health services and why you're so passionate about what you do today.
Well, my experience is very similar to that of many people who take antidepressants and other psychiatric drugs. I was prescribed paroxetine, which is an SSRI antidepressant, in early 2000s by my GP. I was taking 10 milligrams. And over time, the side effects were very upsetting to me. I had sexual dysfunction. I had emotional blunting from the drug, and I was also experiencing demotivation and sluggishness. I wasn't doing anything good for my quality of life. So my GP told me I should see a psychiatrist for the issues I was having with the drug. And I did I saw a psychiatrist from my health plan, which is the way we do things in the United States, who had me switch from 10 milligrams of paroxetine to 10 milligrams of escitalopram, which is another SSRI antidepressant. It was just an immediate switch. So I very shortly, within a few days, developed terrible withdrawal symptoms from going off paroxetine. And when the escitalopram took effect, I had a very dramatic adverse reaction to that. It's a much stronger SSRI than paroxetine, and I was having symptoms of low-grade serotonin toxicity. I was sweating and nervous and shaky and disoriented, and that it was not good. So I ended up going to another psychiatrist. I went back on paroxetine and felt better from that in terms of the withdrawal and, of course, the excess stimulation from the escitalopram. But I still had the other adverse effects from paroxetine, and it just got worse and worse over the course of about a year. I ended up going to a very prestigious clinic that's associated with a very well-known medical center here in San Francisco, and I asked them for assistance in going off of paroxetine, and they basically said, well, there's really no trick to it. You just go off. You've seen advice on the web about it. You just do that. And without any further detail, they didn't even ask me what I'd seen on the web. And so I went off paroxetine over a few weeks in October 2004, and very shortly after that developed severe withdrawal from paroxetine. At that point, I had done some research on it, and I had some papers, some journal articles to show the people, the psychiatrists at the clinic, that I was having paroxetine withdrawal, but they insisted that I wasn't having paroxetine withdrawal, and that they tried to treat me. They tried to prescribe other antidepressants for me, although reinstatement of the original drug is the recommended treatment for antidepressant withdrawal syndrome. So that went on for many months. I got worse and worse. I went to a private psychiatrist, and I got no help from him. He said that I was deluded about having withdrawal. Even after I showed him my journal articles. And I then started, I conducted my own informal poll, I guess you could say, because I started going through the faculty of this medical center. It's a very well-known medical training facility, and none of them could help me with my withdrawal syndrome. Within 30 seconds of the telephone conversation, they all told me I had relapsed. And this was besides the literature that I had found on this, which had been published in prominent medical journals. I also found that the FDA had put a warning on paroxetine in, I think, late 2001 about severe withdrawal. So, and again, this was in 2004. So none of the dozens of psychiatrists that I contacted seemed to be informed about this. I could not find any treatment. I myself didn't have the ability to re-prescribe paroxetine for myself. And I didn't really know what to do. So very reluctantly, I started looking around on the web and found peer support websites. At that time, there were about a half a dozen or so having to do with mostly antidepressant withdrawal, but also people were discussing benzodiazepine withdrawal and withdrawal syndromes from other psychiatric drugs. So I joined one of these websites, which was Paxil Progress. It was a large website at the time, and found thousands of people having the same problem that I had. And I realized that this was a much bigger problem than me not being able to find medical help, but that thousands, maybe even millions of other people were having the same problem. Well, since I really could not find any resolution for the symptoms that I was having, which are really terrible, and there really aren't words to describe withdrawal symptoms, because it's not something that people commonly experience. People don't ordinarily live with these kinds of sensations. Now we have the term brain zaps, which is something that patients made up to describe one of the symptoms, which I did have, which is a really sharp little electrical sensation in your head that comes and goes. It could happen, for 15 minutes at a time or 30 seconds, or it's very random, and it's a really common withdrawal symptom from SSRIs. So aside from that, I had insomnia. I had surges of what I can only describe as anxiety and panic, and also these I called them the black holes. Like they would just come out of the blue, this sense of absolute dread, looking into this dark abyss with absolutely no hope. I was also extremely disoriented. Still, I managed to work for several years, but then it got worse and worse and worse, and I became unable to sleep completely, and I had to stop working. So it was the end of my career, and I was only in my early 50s. Overall, it took about 11 years for me to recover. And I was fortunate in that about 5 years in, I found a psychiatrist who had experience treating adverse effects. And he treated me with extremely small doses of lamotrigine to stabilize my nervous system. But I was so sensitive, I could only take 1.5 milligrams of lamotrigine to, that at most. And he said I was one of those sensitive people he'd ever seen. So, but I did stabilize, although, the lamotrigine did help. It took several years after that to really be able to sleep and to even consider going back to any kind of normal life. And millions of people are going through this. So I started my own website in 2011. It's called survivingantidepressants.org, and it has about 16,000 members now, and with about 300 of them being active at any one time. I set up the site in order to collect histories so that we could study this phenomenon, so that the medical profession could become aware of what was going on. Mm-hmm. And I have about 6,000 of these histories that are fairly complete, showing from patients' accounts what happens after they go off of the drugs, and if we're lucky, how they recover from it.
Wow. I'm listening to your story. One thing that comes to mind is the lack of support out there, and how you had to be so proactive in finding a solution for what, for something that you didn't have any clue, when you first started, but you became an expert by experience because there was no help out there. Surely it must have been very frustrating, to say the least, when you went from door to door looking for help, and it took you so many years before you finally found someone who did help you. Do you think it's still happening even now?
I know that it's still happening because I see people joining my website every day reporting exactly the same thing. Patients are still not able to find the help that they need to go off of antidepressants and other drugs. On my website, people are joining every day telling the same story. There are thousands of people on Facebook seeking the same kind of peer support, and they report exactly the same thing. This is thousands of people all over the world have found that either their doctors really don't know how to taper them off of the drugs so that they don't develop withdrawal symptoms, or that they've follow their doctor's instructions or otherwise gone off the drugs, and the doctors don't recognize that they have withdrawal. So they're seeking help for it, but their doctors simply do not recognize it. And very, very often they're told that they've relapsed, which is, when people have brain zaps, which they've never had before, they can't believe that they've relapsed into depression. Brain zaps are not a characteristic of depression. The people who join my website are people who have rejected their doctor's, I guess you could say, diagnosis, and or found that whatever treatments their doctors recommend are not working, and they've come to a really, really difficult realization that there's no medical help for them. And this is a terrible existential shock to people. It's something that I see all the time, that it's even though people may be having really terrible, uncomfortable, disabling symptoms, feeling that there's no help for them it's a tremendous blow.
Yeah.
I cannot emphasize enough how much this is, it's beyond disappointment. It shakes people's understanding of how their world works,
Yeah.
because we all believe that if we get sick, that medicine will be there for us. But what people are finding is that there's real serious gaps in medical knowledge, and there are things that they cannot rely on their doctors for. And unfortunately, what they're finding is that their only recourse is peer support. And I am not of the opinion that that the patients should be doing it for themselves. I think that they should be able to talk to their doctors. And they should be able to trust their doctors to be able to help them with this extremely common condition. There's so many people taking antidepressants and other psychiatric drugs now, not to mention things like the pain drugs and the sleep drugs, that withdrawal from these drugs is an extremely common problem. Yeah. And doctors are just not prepared for it. It's very, very upsetting.
It is, isn't it? And I'm thinking about my own training in psychiatry. I was never taught about withdrawal symptoms. I didn't know any of this, and I only learned from being on social media and just having an open mind and following people like yourself and James Moore and Joanna Moncrief. I wonder whether you would like to say a bit more about the distinction between withdrawal symptoms and relapse. You mentioned a few things like brain zaps, but could you make it a bit clearer?
Yes, definitely. Let me explain how withdrawal affects all of clinical practice when the doctor is prescribing psychotropics. If the patient has been taking the drug regularly and accidentally forgets a dose or takes it off schedule for a lot of these drugs with short half-lives, that person can set up an instability that they may report as a psychiatric symptom. Patients being irregular in their dosing is extremely common. I believe that I've got a paper that says that it occurs about 30% of the time. It's extremely common. And patients also don't recognize that if they take the drugs off schedule, like, for instance, paroxetine has a half-life of less than 24 hours. If you take paroxetine off schedule, if you take it, let's say, usually at 9 a.m., but you forget it and you take it at noon instead, it's possible that, 1 or 2 or 3 days later, that you're going to feel odd from that irregular dosing because it disturbs the steady state. It causes blood level fluctuations of the drug, and that is what triggers withdrawal symptoms. So withdrawal symptoms don't always, they're not restricted to people going off the drug. They happen probably all through the period of time for a lot of people that they take the drug. This is where a lot of doctors might think that what they're seeing is a relapse while people are taking the drug, and they increase the dosage of the drug. And this becomes a spiral, especially if, let's say, a very, very common withdrawal symptom is insomnia. And then they'll start adding drugs that might assist sleep, like, for instance, mirtazapine or trazodone, or even a sleep drug, or benzodiazepine. So this ends up leading to polypharmacy, and I think that that's really quite important from the clinical point of view. That if you are not alert to the issue of these withdrawal symptoms coming up while people are presumably on maintenance and taking the drug steadily, then you may be misdiagnosing any unusual episodes that occur. If a patient comes in and says, I've been taking my escitalopram every day But it's really strange because I haven't been able to sleep for the last 3 days, and the clinician doesn't ask, were there any times that you accidentally skipped the drug? They may be missing something that's really important. If the person has been taking the drug irregularly or has gone off the drug, the chronology is really significant. What's confusing to clinicians is that sometimes withdrawal doesn't show up immediately. It could happen, the patient could be reporting it sometime later, and this is maybe weeks later. And this is because of several things. One is that the clinician doesn't see the patient every day, so that so you don't know. So a clinician doesn't know exactly when those withdrawal symptoms appear. So if the clinician sees the patient every month or 6 weeks, and the patient shows up and says, "Oh, I got these strange symptoms since going off the drug the last time I saw you," the clinician might not realize their withdrawal symptoms because so much time has passed, but in fact, they may have appeared earlier. Two, patients themselves don't recognize withdrawal symptoms. They think they might have the flu, or that they ate something bad, or their work stress is what's causing them not to be able to sleep, or that they have, if they get like the paresthesias or brain zaps, they might think they're having like they have a neurological disease, and they might need a neurology checkup. Another thing is that mild withdrawal symptoms can turn into severe withdrawal symptoms. And a lot of people, from my observation, when they get the mild withdrawal symptoms, which might be a little bit of a zap here and there, or like some kind of, maybe broken sleep, they'll keep on reducing the drug anyway. They're going to go off the drug completely. And after they go off the drug completely, they think they're going to, what patients say is they're going to power through the symptoms. And so they keep on trying to ignore them until they get much worse. So there are a lot of reasons why clinicians might not hear of withdrawal symptoms until weeks after the person's gone off the drug.
Mm.
So the chronology is essential. What you need to do is you need to ask your patient, have you taken the drug inconsistently? When did you go off? When was your last dose? Since then, have you had any odd symptoms? The pattern becomes really clear because, first of all, if the patient has somatic symptoms, that's withdrawal. Those vomiting, insomnia, sweating, brain zaps, all of those symptoms, they're not characteristic of relapse of depression or whatever. That's withdrawal. So those patients are relatively easy to diagnose, or it's rather easy to distinguish withdrawal from relapse in those patients. Where it's difficult, where clinicians may find difficulty in distinguishing withdrawal from relapse, is, even with the chronology, is if the patient doesn't report any significant physiological symptoms, but says, I can't feel anything, or I've lost all interest in everything, or sometimes the patients will use the language of psychiatric diagnosis and say that they have anhedonia, which is sort of like, our culture has been permeated with the language. I have to emphasize that from what I've seen from thousands and thousands of patients and experienced myself, is that after going off of the drugs, it's extremely, extremely common for people to experience an emotional anesthesia. They do not feel reward from anything that they used to like. They may not feel anything for their children and their spouses. They may not, they may feel just an absolute absence of positive emotion. And this is a consequence of going off the drug. It gradually dissipates as withdrawal symptoms tend to do. Also, if it's if it's accompanied by insomnia, you've got a smoking gun right there. So so I don't believe that this has been recognized enough.
Yeah.
The effect of the drugs leaves a long-lasting footprint on the nervous system. And when the drug is taken away, this, I believe, is unmasked. And the whatever chemical support the drug has provided has been removed. And what the person is experiencing is a nervous system that is, it's an expression of dependence. The nervous system actually is feeling the lack of the drug. It's a withdrawal symptom, and it will gradually go away. It's not relapse, but it's really hard to distinguish because the patient will use language that they'll describe it. It'll sound like relapse. The patient may come in and say, I'm depressed, but you have to ask about what's the quality of your depression. And they go, well, I just am not feeling anything from anything. And that is a consequence of taking the drugs. I know that this may be shocking, but it can last for months, and it's not relapse. Now, ironically, one of the remedies, or the only known medical remedy for withdrawal syndrome, is reinstatement of the drug. And so if the clinician guesses this is relapse and reinstates the drug, yes, that emotional anesthesia may resolve because it's a withdrawal symptom. And it's been resolved because the chemical support is back in the nervous system. However, what I found, and I think that this is one of my discoveries, is that if people reinstate, let's say, even 1 milligram of the drug, it's enough. So even that, I guess if you think of it as a receptor occupancy model that Mark Horowitz has proposed, there's some amount of receptor occupancy is accomplished even by 1 milligram. And that is enough. And if that happens, if you reinstate 1 milligram and the person feels a lot better, you have withdrawal.
What can individual prescribers or health professionals do to support people if someone comes to the door and say that they are struggling with their medication, or they have been struggling to come off their medication?
Well, Ronnie, certainly, I mean, without knowledge of I guess you could say, the domain, it's going to be hard for health professionals to really help that patient. So they have to incorporate this concept of withdrawal into their overall understanding. And I think that engaging the patient more about what are you feeling is going to help a lot to understand, when did these symptoms start? How does it affect you? For therapists, I think it's important to understand that. I really just don't know how this could work without a core understanding that withdrawal symptoms are possible, because therapists would need to be able to reassure their patients that it's a drug reaction and that it will go away someday. With help, people do recover from drug reactions. The knowledge, though, is so key to this. I don't know how this improvement can be made without an understanding that withdrawal is possible. Just opening your ears to patients is really what needs to be done.
Is there anything else that we haven't spoken about today which you think is very important to convey to people?
Well, I just want to say, if there's, it's possible that there will be people who are taking antidepressants and other psychiatric drugs watching this. And I just want to say to them that, you have to also be aware of the possibility that you might develop adverse reactions or withdrawal symptoms from your drugs. I mean, you may not feel anything bad from them. They may be helpful for you, but they are powerful drugs. And if you take them inconsistently, or if you skip doses, or if you abruptly discontinue, that could cause big problems for you. So be very careful with your drugs. Respect those drugs.
Yeah. Thank you, Adele. Finally, I would just like to say that, thank goodness for people like yourself with your tireless effort to make this problem known to more and more people out there, not just people who are taking medications themselves, but also clinicians such as myself. I just wanted to thank you from the bottom of my heart for all the hard work you have done, because I see you as such an expert in this topic, and we are very grateful.